All right, welcome back. So picture this. You're in clinic, you've got a patient with diarrhea, abdominal pain, and the scope shows inflammation in the colon. Your first thought, IBD, right? Well, maybe, but not so fast. Today we're going to build the ultimate differential for that patient whose colitis isn't Crohn's or ulcerative colitis. And for any trainee, this is a super common, really important clinical problem, so let's just dive right in.
So this is the million-dollar question, isn't it? You've confirmed there's colitis, but the classic IBD picture just isn't fitting, or you just need to be thorough and rule out the mimics. Honestly, building a systematic differential diagnosis is one of the most crucial skills you'll develop in GI, and this explainer is designed to give you a really solid framework for that.
So here's our game plan for today. First, we're going to frame the differential diagnosis. Then we'll get into a crash course on infectious colitis. After that, we'll uncover the secrets of microscopic colitis, a really sneaky one. Then we'll talk about iatrogenic colitis, which is basically when treatment itself is the problem. And we'll wrap it all up with a high-yield recap to make sure all the key points really stick.
Look, while inflammatory bowel disease is always high on the list for anyone with chronic inflammation in their colon, you have to consider a much broader differential. It's absolutely critical. I mean, think about it. Misdiagnosing an infection as IBD and starting immunosuppressants could be a disaster. So let's get to work building out that differential.
Okay, let's jump into our first big category. You're going to see this a ton. Infectious colitis is incredibly common, and man, it can look exactly like an IBD flare. A good history is your best friend here. You're listening for things like an acute onset, fever, recent travel, maybe some suspicious food, but you also need to know the specific personalities of the main culprits.
So this is super high-yield stuff for telling these bugs apart. For Campylobacter, the big clue is that it often starts with a prodrome, fever and headaches before the diarrhea hits. That can really point you in the right direction. Now, with Salmonella, the main takeaway is, believe it or not, to hold off on antibiotics in most cases. They can actually make the person shed the bacteria for longer. And finally, E. histolytica. When you hear that, think amoebic colitis, especially in patients with a history of travel. And if you get a biopsy, that classic textbook finding is flask-shaped ulcers. That's a buzzword you definitely want to remember.
All right, next up is a diagnosis you absolutely have to have on your radar because it's a true wolf in sheep's clothing. We're talking about microscopic colitis. It's a huge cause of chronic watery diarrhea, especially in older adults. And here's the kicker. The colon can look totally normal to the naked eye during a colonoscopy. The only way to catch it is with biopsies.
So microscopic colitis really comes in two main flavors, lymphocytic and collagenous. And just like their names suggest, the difference is all about what the pathologist sees under the microscope. In lymphocytic colitis, or LC, you've got way too many lymphocytes hanging out in the colon's lining. In collagenous colitis, or CC, the signature finding is this thickened band of collagen right underneath that lining. Both are more common in women, but check out that 7-to-1 ratio in LC. That's a pretty striking difference.
So speaking of that thickened collagen band, there is a magic number you need to know, 10. So what's so important about the number 10?
And here it is. For a pathologist to officially call it collagenous colitis, that pink band of collagen they see on the biopsy has to measure more than 10 microns thick. It's a hard, measurable number that makes the diagnosis. It's just a fantastic, easy-to-remember clinical pearl.
Okay, so beyond the microscope, your patient's history can give you some major clues. Microscopic colitis has strong ties to other autoimmune conditions, especially celiac disease. And you've got to look really closely at that medication list. Super common drugs like PPIs, NSAIDs, and SSRIs are all well-known triggers. Smoking is also a big risk factor. So, if you've got a patient with chronic watery diarrhea plus any of these factors, you have to be thinking about microscopic colitis.
Let's shift gears to our final category, and it's one that's becoming more and more important in medicine. This is iatrogenic colitis. In other words, colitis caused by our own medical treatments. From new cancer therapies to radiation, sometimes our best interventions can take a toll on the colon.
One of the biggest players here is colitis from immune checkpoint inhibitors. These drugs have been a game changer for cancer treatment. They basically work by taking the brakes off the immune system so it can go fight cancer. The problem is, this newly unleashed immune system can sometimes attack healthy tissues, like the colon, causing a really severe colitis that can look just like an IBD flare.
Another really common scenario is injury after pelvic radiation, say for prostate or cervical cancer. Now, people often just call this radiation proctitis, but a more accurate term for the chronic bleeding that can happen is RAV.
That stands for radiation-associated vascular ectasia. So instead of just diffuse inflammation, the real problem is the formation of all these fragile, dilated blood vessels, telangiectasias, that just love to bleed.
All right, we've covered a ton of ground. We've talked about bugs, we've looked at biopsies, and we've covered the side effects of some really cutting-edge therapies. So now, let's boil all of this down into a practical summary that you can take with you and use on the wards tomorrow.
This table right here is your cheat sheet. For an infectious cause, you're thinking acute onset, fever, travel history, and your first move is stool studies. For microscopic colitis, the story is chronic watery diarrhea, and the absolute must-do is to take biopsies from a colon that looks normal. For checkpoint inhibitor colitis, the context of cancer therapy is everything. And finally, for radiation injury, it all comes down to that history of pelvic radiation and seeing those classic rave findings when you scope them. So, if there's one thing to take away, it's this. Not all colitis is IBD. Keeping these mimics on your differential is what separates a good clinician from a great one. So the next time you see a patient with colonic inflammation, you'll have this framework to think through all the possibilities, not just the obvious ones. So which of these great mimics do you think you'll see first? Thanks for joining me.